Chang and Dr. Siva, because I know on a Saturday morning you could be doing many things. So thanks so much for your support to NewMed and to the team here, right? So thanks so much also for advising the students and getting this event on a yearly basis. But of course, the real superstars are all of you, right? Okay, the students, I know as a medical student's mother, all right, I know how tough it is in medical school, right? And how you guys are always, having formatives and clinical sessions and things to do. As a biochemist myself, so I'm like you, the BMS students, right? Okay, I know also it's not so easy. You got your research here, you got a lot of assignments and everything. So thanks for taking that time off and doing something that is dear to your hearts, because I'm sure you join societies because it's something that's dear to your heart. Now I want to say something about the World AIDS Day. So I got to know a bit more about the kind of AIDS activism and efforts in our part of the world. Because when I was in IMU, right, Dr. Juria Abdullah, who is the wife of Dr. Christopher Lee, she's a very dear friend, very close friend. She opened my eyes on this, right? And we ran a campaign at IMU where we wanted to put some drama, dot, because no one is untouched by AIDS. And the point at that time was, I'm talking, this is about year 2000, 2001, This is not even 1980s, 1990s. This was 2000s and still a lot of stigma around that, right? And what we did is we actually drew a circle, right? And then we draw another circle around it, and then another circle. And what hit us was one of our students and graduate actually passed away from AIDS at that time. So you see, your point of connection to people, it's actually quite close than you think, right? So you cannot ignore things or diseases, whether it's HIV infection or any other kind of condition, even mental health, right? No one is untouched. The circle becomes smaller and smaller if we do not do anything about it, right? So it could be actually a family member one day. It could be, as I said, a student that we love, right? So this is something that was quite close to our heart. So we did quite a few events. And one of the things we also did with, of course, consent, and I think the Malaysian AIDS Society was really good in, I mean, I don't have much interaction now, but at that time, really getting patient advocacy in. And we used to have patients to come and talk to us and, and also trying to remove that stereotyping and stigma, when you do your rotations and any of you get the opportunity to work with in the hospital with the ID team, you will see a diverse group of people, right? Everyone with their story and narrative. And we got to respect that. So I'm so pleased to see that. I was a bit sad to hear that there's still a bit of stigma and everything, because I'm thinking now it's 2023. To be honest, even myself, I thought, okay, we are advanced to that when it comes to infectious diseases, right? But looks like there's still some stigma in community and everything, right? And so what work you're doing and what awareness that you're doing and what you're going to bring into practice, I think is going to be very important, right? So thank you for having the event. Thank you for having me. And I look forward. I can't stay for the whole event because I've got, to be honest, this is one thing I want to say to all of you. Don't take more than what you can handle. And I'm so kind when people ask me to mark PhD thesis. So I love reading new things. So I find that when you're forced to be an examiner, you actually have to read new things. So I accepted two, one from USM and one from Leeds University. And the deadlines are all before Christmas. So I have to go and do my due diligence for that, right? So, but I'll stay until the refreshment and I hope to hear from you. Siva, I know Dr. Siva's wife pretty well and got to know him over the few years. So you can tell me about your work over dinner.
Give you a personal session.
Personal session, yes. So thank you so much. And I really appreciate students doing this. And if you need any further support, from the university or personally from me, because I do have some contacts here and there also. Of course, Prof. Ed also does, but we try to do something more impactful for our community here, right? So thank you very much. Yeah.
Thank you, Professor Fishner, for taking your time to come here today. It really means a lot to all of us. But right now, we're going to be testing everyone's knowledge regarding to AIDS and HIV in particular. So it's going to be hosted by my committee members, Raj and Jinxie. Yeah.
So we'll start with some simple MCQs. Just scan the QR code here. So the first question would be, what does the acronym AIDS stands for? So the correct answer will be acquired immune deficiency syndrome. So let's proceed to the next question. So the second question would be, which virus is responsible for causing AIDS? So let's see the correct answer. The correct answer will be HIV, which is human immunodeficiency virus. So the next question. What is the primary mode of transmission of HIV? So the answer will be unprotected sexual contact. So other than unprotected sexual contact, HIV can also be transmitted from an infected mother to their child during childbirth or breastfeeding, and even sharing of contaminated needle.
So the next question is, what is the common early symptoms of HIV infection? So that is correct. Fever, fatigue, and swollen glands. Also rash. All of these are symptoms of a weakened immune system. The last question. Select one method of preventing transmission of HIV. So that is the correct answer. Practicing safe sex is a method of preventing HIV transmission. Okay, so this is the end of our question session. Thank you very much for participating.
Thank you, Raj and Jinxie. So actually, we're going to be commencing with our speakers. So first off, our first speaker for this event is Dr. Chang Chi-ik. So actually, just a little bit of information about him. He is a specialist in infectious diseases at HSA, and he's been a member of the Royal College of Physicians in 2016, and has been serving as the internal medicine physician in the Ministry of Health in Malaysia since 2019, and actually He published a wide variety of papers, and some of his papers includes studying more on HIV immunocompromised patients toward different kinds of diseases, whether it's fungal or bacterial infectious diseases. And today he'll be talking more about the current HIV epidemic in Malaysia. So please give a warm welcome to Dr. Chang.
So I should look here or look back? Okay. So good morning to everyone. So it's my great honor to be here, to be invited as a speaker to talk to you guys about the current HIV epidemic in Malaysia. So I still can remember clearly that I actually gave this talk 3 years ago when I was here in JP. So over the years, as I was preparing the slides, you know, the sad thing is things hasn't changed that much, right? I mean, as HIV clinicians, you are always looking forward to better changes, you know, a better health and all that for our patients. But so let's see what we have been doing over the years, right? So this is the outline of my talk, and I'll move to HIV prevalence and epidemiology. So this graph actually shows that there are about 82,000 people living with HIV in Malaysia. And as the incidence of HIV actually generally increases, as you can see that we are actually having a new diagnosis of HIV about 5,000 a year, right? So despite of this increment of the cases of HIV, as you can see, the AIDS-related death has remained constant at about 1,600 per year. So this is hugely related to the success in terms of a better preventive treatment and also a more effective antiretroviral. So this looks into the proportion of gender in terms of patients living with HIV. As you can see, out of that 82,000 people, 20% of them are women. So I think the thing is that women are sometimes being neglected in care, right? So they don't get that access or linkage to care that well, okay? And this graph basically showed the incidence of new HIV diagnoses over the 3 decades. As you can see, the cases of new HIV diagnosis has been reducing trend over the past decade. So this is the proportion of patients, the key population, according to the way that the HIV is being acquired. So you can see that the main risk factors in our current HIV population is actually men who have sex with men, followed by people who inject drugs, and female sex workers, and also transgender also make up about 15,000. So this is HIV prevalence among key population by age group. Okay, so what you can see here is that for the MSM group, actually they are, you can see that there's actually a high incidence even for people less than 25 years old. And so this is the key prevalence, HIV prevalence among key population by sites. So you can see if in people who inject drugs, right? So the highest prevalence of HIV is actually in Kelantan. And whereas in metropolitan city like KL and Johor, it will be either transgender and also the MSM. So this bar chart actually showed the distribution of reported HIV cases by mode of transmission, right? So in the mid-80s, where the HIV pandemic started, so the cases of HIV are being dominated by people who inject drugs, right? Changes. Oh. So let's move on. So And yeah, the commonest mode of transmission by then is in people who inject drugs. It's not moving. Okay, it's okay.
Yeah, sorry, I'm so sorry.
Okay.
Working now?
Yep, it's okay now. Thanks. So starting the years of 2000s, that's where there's an increment in the new cases of HIV diagnosis among heterosexuals. So what is the current trend now is that over the past 2 decades, there's a sharp increase in HIV diagnosis among the people with men who have sex with men. So vertical transmission has been contributed to a minimal of cases each year. Okay, so we look into the risk behaviors, right? So you know that just now we talk about the mode of transmission of HIV, which include sexual transmission. That's why we talk of sex, right? And also people who inject drugs, sharing needles. Okay, so we look into the key population that reported condom use. So over the years, the knowledge on HIV and how to prevent HIV has improved. That's why you can see that the knowledge and also the condom use has also increased over the past 1 decade throughout this survey has been done. So we talk about sharing needles as a major risk of acquisition of HIV. So because of the knowledge that we can actually transmit this HIV virus through sharing needles. So actually using a sterile injecting equipments could actually reduce markedly the risk of HIV transmission. So the proportion of patients who inject drugs, which they have already started to use a more sterile injecting equipments. So people with living with HIV, they do actually have multiple risk factors, or they do share some risk behaviors commonly. So in people who transgender, men who have sex with men and with female sexual workers, quite substantial proportion of them actually also consume alcohol before sex. So this also increases the risk of sexual activities. So interesting to talk about the vulnerability and HIV knowledge, especially among not only among the treating clinicians or doctors, or also among the publics. So this is a survey done on testing the HIV knowledge among the key population, right? So you can see over the years, the HIV knowledge actually increased because of organization of all these public events or campaigns and all that. So, but generally the HIV knowledge among the key population are still poor. Okay. So this is somehow I find that a bit surprising is that although HIV has been around with us for over the past 4 decades, so this is a survey done on the national service trainees. Okay, they are aged 17 to 19, testing on their knowledge on HIV, and it is surprising to find that actually about 3/4 of them do not actually have a good knowledge on HIV. Yeah, so education has to start from the youngs. Okay, there's no point that we educate people when they are actually already engaged in high-risk activities. So let's talk about HIV expenditure in general. Okay, so this is how much on average Malaysian government is spending on AIDS or HIV. Okay, about 20.7 million, where majority of the fund is actually coming from domestic funding. Only 8% are contributed by international funding. So about for this 20.7 million US dollars has been spent. So the majority or almost half of this money is being spent on key population prevention, and the substantial amount of those funds are being spent on care and also treatment of HIV positive patients. So this is the trend of financing the, all the AIDS and HIV activities and care from 2008 to 2000. So as you can see, the big proportion of the money is being spent on care and treatment. Okay, and we are not spending much on prevention. So to actually reduce all this spending, we need to talk about prevention. Okay, so prevention is better than cure. Okay. So what are the national response to the HIV epidemic? Right. So the first thing is we need to get all of them tested and treated. Okay, because by treatment, you can reduce transmission. That's why we always talk about U equals to U. Okay, means that undetectable viral load would translate into untransmittable. So one of the way of bringing down the HIV new diagnosis is actually by scaling up our antiretroviral therapy. So as what you can see is that among that 82,000 people who live with HIV, about 45,000 of them are actually being treated with antiretroviral therapy. And you can see our ART coverage is about 55% nationally. So in order to actually allow a better access for the patients to come forward for care and, so that they don't drop out from the service. So there are more and more healthcare facilities are providing this ART treatment for our patients. As you can see, there are a total of, if you compare that data back to 2007, there are only about 281 sites that actually provide care for HIV patients. But over the past 10 years, and that has been increased to 1,400 sites. So this means that patients can actually get care at better accessibility to care. So to bring down the HIV in general, you also need to talk about testing, because testing always comes first. Okay, so testing, you talk about people, if we live with HIV who know their status, if you compare side by side, women and men, so there are higher proportion of men actually knows their diagnosis. So that's why I said we need to actually promote testing, especially in vulnerable category of people, especially our women. Okay, and there are about 62% of these females are on treatment, and men, they're about 52%. So this is the estimated, so we talk about the estimated adults who live with HIV, about 82,000 in Malaysia. So about 45,000 of them are receiving antiretroviral therapy, and that covers about 55% nationally. So this is the treatment cascade. Okay, so you have 82,000 patients who is living with HIV, and there are 67,000 of them who know their status. So in this number, there are 45,000 of patients are on antiretroviral therapy, and there are only half of those people who are on ARV had viral load suppressed. So the reason why we are testing viral load is one of the most important parameters that we look at to see if the treatment is working or successful or not. Okay, so this is the target. So this bar chart actually shows that we are still quite far behind from achieving our target. So we are targeting about 95% of people who live with HIV to know their status. But at the moment, up to 2021, there are only 83% Okay, so we still have a huge gap to actually meet the target of 95%. So there are about 55% of people who live with HIV on treatment. So we are far away from achieving that 90% of people who are on treatment. And we're supposed to actually achieve 86% and above for people with HIV that have viral load suppression on therapy. But we are only achieving up to 45%. Okay, this means that there's still a lot of work to be done to actually improve on this. So the last part would be talking a bit on the treatment of HIV. So about half of the key population actually do not know their status. That is why they present very late with opportunistic infections. Okay, so but how do we go about it? We should talk about assisting testing and also self-testing. Okay, and this will be helpful in increasing the HIV diagnosis and to link them to care. Okay, so among all these key population, the testing only covers about half of these people at most. Yeah. So if we talk about achieving target of 90 by 2020, and it is now 2023. So where are we heading? Which direction are we heading now? So by the target that we have set to be 90, we are supposed to actually have 4.2 million people on antiretroviral therapy. But by the year of 2020, there are only 3.7 million people are on therapy. So which means that we are still have short of 0.5 million. So where are these people? Okay, so we have to work harder to catch them, to diagnose them, and to start them on treatment. So this is the report card, right? So globally, the achievement has been 84%, 87%, 90% for people who live with HIV to know their status on treatment and also achieve viral load suppression respectively. So generally, the Asia and Pacific regions has not done that well in terms of getting people to, getting HIV patients to actually know their status, okay? So let's look at, this is comparison, okay, where Malaysia stands in terms of the ARV coverage. So we are not doing that well, okay, as compared to more developed countries like Australia, New Zealand, Thailand, and China. So our ART coverage is only 51%. So there are a huge treatment gap that exists. So children is another group of vulnerable group of patients. So these are the patients that the common mode of transmission would be by vertical transmission. All right. So in Malaysia, our ART coverage is actually still below par. Okay, so it's 80%. So about 4 out of 5 children living with HIV are actually receiving ARV in Malaysia. So I think Prof. Ed has done a study, right, on late diagnosis, and it is not surprising to actually find that no patients that actually come to our clinic at HSA are late presenters. So how are we going to, improve on that? So, so in Malaysia, generally, there are 41% of them who actually present very late, advanced stage, when their CD4 count is actually below 200, right? So these are the a list of antiretroviral drugs that are available in Malaysia. Okay, so you can find this in the Malaysian consensus guideline. Okay, so this is what has been agreed to be the preferred ARV regime. Okay, so I think we are moving towards that. Okay, so access to better drugs, with better tolerability and effectiveness. So hopefully we will do better in terms of getting our patients on more effective treatment with negligible side effects. And that is the main aim. So it's something that the Malaysians should be congratulated on, right? So because Malaysia is the first country, one of the first country in the region to actually eliminate mother-to-child HIV and syphilis transmission. This is dated back in 2018. So in 2021, there are about 200 in excess of 200 patients, pregnant patients actually live with HIV, and almost all of them are actually receiving antiretroviral drugs. And this is important in terms of preventing mother-to-child transmission of HIV. Okay. So Malaysia, being the first country to be able to achieve that status, together with Thailand, Vietnam, and Cambodia. Right? So after talking so much, so we need to know like what is our effort. Okay. So what I think will be very useful to create awareness among all these people that to come forward for is actually a national HIV testing, okay, a referral and HIV self-testing. I think Thailand has done very well in terms of advocating self-testing. I think we are also working towards that. And partner referral, provider referral, and also there's an initiative on stigma and discrimination reduction. As we know, stigma still exists, up to date. And by reducing the stigma, I think this is the most effective way that more people can come forward for treatment. All right, with stigma, people will not come to hospitals or clinics. So treatment literacy, okay, training for trainers, that is in Klang Valley. And what has been actively being done over the past few years is that we actually have delivery of PrEP service, that's preventive treatment, okay, primary care, the pre-exposure prophylaxis. So this has been ongoing as far as I know. So you have the treatment cascade study, and you have the IBBS study, which is more of like a data collection for the region, right? So these are the key changes that has been progressed over the past few years, right? So that's also my talk. Thank you so much.
Thank you, Dr. Chang, for this wonderful talk about HIV epidemic in Malaysia. Now we'll be proceeding to refreshments. However, before we go and have our refreshments, can we please take a group picture together, if it's possible? Okay. Yeah, and also, guys, this is being broadcasted on YouTube on live, so whoever couldn't make it today, please encourage them to also view our live stream. It's up and working right now. So yeah.
Can we ask some questions?
Yeah.
Do we have time at all?
We can ask if there's, yeah, we already have time anyway, because we're ahead of schedule. So if you guys have any questions to our fellow speakers after their individual talk, you can do that. Otherwise, you can think of questions for them for our Q&A session, which will happen at 12:50. Yeah. Yeah, you can.
Thanks so much for the talk. So, as I said, for me, my awareness started many years ago. But I see data still is very patchy. Right? Some of the data that you showed is 10 years or what is the challenge for researchers to get the data? If you talk about treatment, I'm just putting the other head for treatment and all to happen and for decision making, data seems to be a bit patchy because you showed some data even from 2008 in your slides, for Malaysia at least. Yeah.
Yeah, Prof. Actually, all this data was actually non-existent before. So even this is actually, you can find that. I think that's this is the I think the UNHIV.
UNAIDS.
Yeah, UNAIDS. So all these data are being compiled and all the countries have to submit the data. So I think the data collection will be better from now on with a better system that they can actually collect and analyze the data. I think the data was really patchy, like what Prof has mentioned earlier, because it's just and also I think the problem is about dissemination of data. Once you have the data, but it cannot be disseminated to the audience or to the public, that is also a problem. But by now, I think these are all being uploaded on the website. So anybody who had interest on it can just look up for it. It's all in the data.
I think the comment I'm making is actually for our audience here, especially future scientists, future clinicians. It also meant that it's our responsibility not to just be in that treatment side, but like how Dr. Chang is, right? He's so active in research and, Dr. Ed. So it's actually putting from the Malaysian side, right? Instead of depending on UNHCR, applying for grants amongst with our clinical colleagues and our scientific colleagues and, an interprofessional kind of initiative to actually look into solutions that are contextual for our country. Because one of the things that you had not mentioned, you did not mention, but I think each state, right, we saw the different statistics, but there are different stigmas and contexts that prevent treatment and access from each state. So Kelantan is different from Johor, right, or from KL.
Exactly.
So that's why research is needed, right? But the big guys are not interested. They want general global data. So only we should be interested in our data. So that's the thing I was thinking. But thanks so much. Really happy I came to hear this. Yeah.
Thank you.
Just your thoughts on this, Chan. When you talked about the missing population, how much we have achieved and how much we have to achieve, and your question was, where are these people? I was also thinking, who are these people? My thoughts are that they most probably would be among the MSM population. But that's a huge number. What are your thoughts? I just wanted to hear your thoughts with regards to this, because I think we're doing a good job detecting people who are not from the LGBTIQ community. The question is, are we doing a good job actually penetrating into these most at-risk communities?
I'm talking on the real life scenarios now when I sit in the clinics. Yeah, I would say about in among 10 patients that I see with new HIV diagnosis, I would say about 9 of them are actually coming from people who have sex with men. So I think most of the effort probably should be focused on this key population. And I think one of the ways is the referral system, okay? Because some of them, when they come, they probably had multiple partners and all that. So they should actually guide all the partners to actually come forward for testing. Yeah, I think we should move on to self-testing. I think self-testing is probably the way to go.
$6 million question. Sure. I'm going to touch a little bit on this. Okay, on it's 25. It's diagnosing the undiagnosed, okay, which is a huge challenge. And I can also just going to touch on what's just being released yesterday in the United Kingdom about a pilot study about opt-out testing in A&E department when 22 hospitals And in that short-term project, and I've done a bit of this 12 years ago in my own trust, they actually diagnosed over 600 patients over a 6-month period just by using an opt-out testing system. So the mathematical model in United Kingdom, and we don't have one here, okay, and that's actually quite a focus of research that we need to look at. It's estimated in United Kingdom that there are at least 6,500 undiagnosed population out in the community. The people who have not perceived themselves to be at risk as well, okay, that have not come forward to be tested. And that's why we have got all these lab presenters, okay, in that context. But that's a real encouraging the younger population here, a real area of research, okay, in terms of how are we going to reach this population? Yeah.
Actually, I have a question towards Dr. Ed and Dr. Chang. So, sir, Dr. Chang, you've mentioned about like sort of like how hospitals can maybe perhaps play an important role in this. So I would like to ask, perhaps what should local institutions or local hospitals do to ensure that perhaps there's resources available for perhaps Malaysians who are underprivileged or don't have access to these resources? How can we ensure that they're getting the right kind of treatment or they're getting diagnosed? Because, you know, there's people who go undetected towards testing for HIV, and that, you know, contributes like a large amount of data to why they're like having a low CD4 count and whatnot.
I think we are very fortunate to be living in this land that, you know, for first line therapy, you know, all antiretrovirals are actually free, right? So it's just a matter of linking them to care so that they actually can receive an effective antiretroviral therapy, because that is the only way to get them healthy, right? As what we said, we are dealing with a lot of late presenters. So our main challenges is that we're probably spending a lot of money on treating them as an inpatient, because they often are being diagnosed with all these opportunistic infections. So the benefit, if we actually manage to diagnose them early, start them early on treatment, and they probably don't need to be admitted at all for any opportunistic infections, which can be life-threatening. And we're talking about serious or significant morbidity and mortality every time they get admitted to the hospital. Yeah, Prof. Ed, I'm not sure what else you need to add.
Good morning, everyone. This is not a question, it's more for my personal curiosity. I may have missed some of the data, one of which is 82,000 people in Malaysia with AIDS. That is under the purview of the ministry or the general population. Malaysia has about 31 million people. And then there's one slide, can you just play that back again, where we to attain about, don't know how many million people on ART.
No, I think what the Asia Pacific region.
Wow.
Yeah, it's Asia Pacific region.
Yeah.
Okay, not relation.
That's all the numbers. Thank you.
Region.
Do you have any other questions that you'd like to ask Dr. Chang? Thank you, Dr. Chang. Can you please give him a round of applause? Can I ask everyone if we can all just gather together here so we can take the pictures? Actually, guys, can I ask everyone to stand here? We'll just all be all together, and then we're gonna be taking picture behind the slides. Yeah. Just changed. Sorry. Yeah. Put it on presenting mode. You're being big. Okay. You wanna take the picture? Okay, just get it.
Can we just do one more?
Okay, so we're gonna have to do it, okay? That's very good. Because the thing is, with the 0.5, everyone has to try to squeeze it together,
Yeah.
because not everything can fit. So if you guys can just come closer. Okay, there's some- No, we can't switch down. Can't switch down. Everyone,
Hey.
1, 2, 3.
Thank you.
Okay, see, I'm trying.
Everybody has access.
Nice. You're done.
There were questions are outside and ready for you. Yeah, okay, like, if you want to put it short, I don't know. Everyone is here. It's okay, yeah, it's okay, what's the, I'm open to hear with everyone.
Don't take this one. Just doesn't.
No. Okay, so good morning, everyone. I am Jingwen, a NUMED alumna and also a current teaching fellow. I'd like to introduce our second speaker, Professor Edmund Ong. So Prophet is our honorary professor of medicine at NUMED and also consultant physician at Hospital Sultanah Aminah. He's trained in infectious disease, tropical medicine, and general internal medicine. Prophet has a great interest in the field of opportunistic infections, antimicrobial agents, clinical epidemiology, audit, and also healthcare quality improvement. He published a lot of peer-reviewed journals, papers on the peer-reviewed journals, and also numerous textbooks on infection. He's a international global advisor for the Royal College of Physicians, London, also a member and a former chairperson of the British HIV Association Audit and Standard of Care Committee. So, all right, let's welcome Prophet to share his talk on the 2025 UNAIDS target today. Okay, welcome.
Thank you. Thank you very much. Okay. This morning, okay, on a Saturday morning, probably on your day off, okay, and I'm delighted to be sharing with you some of the information as far as HIV globally is concerned. I'm delighted that Dr. Chang has updated you about the situation in Malaysia. But let me just actually put a bit of things in perspective, because there are a lot of things that's happening outside Malaysia as well. That does have an impact of what actually happening here in Malaysia. The UNAIDS target of 90-90-90 came about in 2014. It's a UNAIDS program with partners thinking through in terms of how best can we actually innovate to try to end transmission of HIV. You may have read journals and things thinking about, ending AIDS. Okay, yes, you need to stop transmitting HIV first in the context of the global picture. So can the UNAIDS 90-90-90, which was set out in 2014, be achieved? So this is a very interesting systemic analysis looking at 169 published data on the treatment targets of each individual country to see whether this can be achieved or not, okay? And what did it come up with, okay? It come up with that I would actually look at B first, okay, the chart there at B. So you can see that when 2014, when the 90-90-90 first was set out, at that time, there was 36.9 million people, as much as they can ascertain, living with HIV, okay, in the context that at that time, 13.4 million people were undiagnosed, 54%, 14.9 people untreated, 41%, 15.3 million people not virological, 32%. So when they actually look at, okay, the 90-90 targets in 2020, okay, because there's obviously the publication was actually published in 2022, okay, in the context that you can see, yep, 90%, 81%, 43%. So what Dr. Chang showed it to you in Malaysia. So obviously, Malaysia, the figures is even much lower. Okay, and that's why this is a global assessment to see how the 1990 targets have been actually achieved over that period of time. So, quite fortunate that when I was actually updating my slide set, this only came out literally several weeks ago. The 2023 UN AIDS Global AIDS Update, the path that ends AIDS. I think obviously they want it to have title that is have an impact. Okay, in the context, yes, you can end AIDS if you have diagnosed someone with HIV and therefore put them on treatment because they can subsequently live a normal life. Therefore, will not actually progress on to having AIDS. So I think they want to have a statement that have an impact to the general public. Obviously, you and I says that if you think about it, this is actually the transmission of HIV that we should actually target first, okay? Because we need to actually identify the undiagnosed, okay? Because otherwise, the transmission is actually going to continue. Right, so look at some of this world global data, okay? There are numbers of new infections that are increasing in some countries with sizable epidemic. Okay, so the one that I just want you to concentrate, okay, is actually the red bit. I'm not sure whether the front lights can be dimmed down. Can be seen a bit closer. I'm not quite sure. Okay, so if you can see, okay, the red bits, right? So, yeah, wonderful. Thank you. Excellent. Okay, you can see that Central Africa are the areas, okay, that has got some of those issues. Okay, and if you look at the Asia Pacific area, okay, into the bits of that area, okay, which we are very concerned about, Philippines, okay, is one of actually a very high newly diagnosed areas where you get increasing numbers. We actually had last summer, okay, we had a conference here where we had a lot of Filipino doctors that came, and then they were obviously sharing with us some of those worrying data that Philippines is actually witnessing, you know, in that context. So, right, we really focus in terms of treatment access. Because if you think that actual fact, if you implement HIV treatment, you can more or less, okay, reduce the number of deaths. And with highly active antiretroviral therapy, between 1996 and 2022, we have actually reduced 20.8 million AIDS-related deaths. That's been averted. So tell me, what other major intervention in medicine that could actually have such an impact in reducing mortality, okay? And I think that's something that we must be aware of, okay, in the context, and that's why we need to be really focused on how we're going to actually achieve some of those targets that we want to actually focus on to reduce transmission. Right, so the world as a whole, okay, this is new now, like a number of new infection in the world as a whole, 2022. Always a year lapse of the report, okay? The world as a whole, there were unfortunately still 1.3 million people newly diagnosed with HIV. So if you look in the world as a whole, where are the key areas that we should be focusing on? Okay, and I think it was highlighted too by Dr. Chang just now. Asia and Pacific region, okay, the Asia and Pacific region, there is 300,000. Okay, and which are the other area, okay, in the world as a whole, Eastern and Southern Africa, okay, where I do actually have a project in Southern Africa, and then Western and Central Africa, right, and Caribbean, and Latin America is an area where they are very concerned about, Eastern Europe, okay, and Middle East, yes, there's been 17,000, but that is not as markedly as as what one would think, and there has been a bit of anxiety whether this is actually a little bit underestimated, okay, because of access to actually testing. And just to show you as well, okay, in the context of funding, so therefore I'm not going to dwell too much on it too much because this has been highlighted by Dr. Chang previously. The global HIV funding gap is widening, okay, in the context, because if you look, Global Fund has actually been relatively stable. Okay, that's the blue bar chart, but the red bits are the domestic public bit. Okay, which is actually practically stagnant. But as a whole, okay, we actually do not actually see that in the next 3 years' time that we're going to achieve that resource needs, because if you collectively, it's about 20.8, but it's 29.3 that one need, okay, to actually trying to achieve the targets that we've set ourselves to. So while are these targets being set, what are focus of the area? Okay, you're talking about provide accessible HIV prevention and treatment services to protect people's health and well-being, variety approaches that relies to protect human rights, and I'll talk to you, okay, in terms of the whole issue about human rights, remove, okay, the society and structural inequalities to HIV-related services and resources and tools, collect and use reliable granular timing data. We were talking about data reliability and validity of data. Build and maintain strong political commitment, whether you like it, okay, you need the politicians to be on board, okay, to actually drive some of these issues, okay. Engage affected communities. I'm really that you're going to have Professor Shiva as the next speaker, okay, and to talk about Let Communities Lead, which is this year's World AIDS, okay, message, okay, and I think we must not forget, okay, the people that we care for, okay, in the context that one needs to actually instill leadership, respects to them, and then you ensure equitable access to medicines and other health technologies, and fully fund reliant, integrated, accessible public and community healthcare system, and adapt innovative approach. I have been quite impressed with the way scale it in parts, but at least it has start, okay? And I'll share with you some of the experiences that I have and been very fortunate to be invited to see some of the community work that some of this innovation has been implemented. So I'm not going to talk too much about this, but I want to actually show you in the global scale in terms of knowledge of FIV status, treatment, viral load, suppression have risen substantially. But have a look, there's still a gap, okay? It's not 90, okay? In the context that if you look at 2015, 71%, yes, it's gone up to 86%. That is when people living with HIV who know their HIV status, people living with HIV who are on treatment, yes, it has gone up substantially. Great story in terms of in 2015, it was only 48%. Now it's gone up to 56%. And people living with HIV who are virologically suppressed, 71%. So there has been an improvement, but not the target of 1990. So unfortunately, I don't think, okay, we are going to actually be able to stop transmission just yet, but we mustn't lose faith. Okay, we mustn't lose faith. Okay, in the context. So, success story. Okay, and I'm not going to dwell too much. This is world as a whole. Okay, Malaysia should be proud of this. Okay, in terms of interrupting vertical transmission, and we can say 3.4 million new infections averted among children. Wow. Okay, between this period of time. Okay, I think it's been really, really encouraging, and access to actually antiretroviral therapy for pregnant and breastfeeding women. The question that you were actually asked this morning is about transmission of HIV. Breastfeeding is obviously a bodily fluid, but one has to be practical. In South Africa and Nigeria, where I have got 2 projects, people are so poor, okay? People are so with limited resources. With a pregnant mom, are you going to ask the pregnant mom not to breastfeed your child? Because the child is likely going to die from malnutrition, the HIV. But we are quite fortunate if you actually start them on antiretroviral therapy, the marked decrease in transmission. Okay, so I think one has to be practical in that context in terms of reality of life. Okay, in the context. So, yeah, okay, and I'm going to talk a little bit about the context. These are some of this hard to reach population has taken days to come and attend your clinic. Okay, are you expecting them to come back and to get a treatment? No, you want to actually start them there and then. Okay, in the context of same-day access and in context. So I can go on for hours in this particular subject of TB. Okay, I mean, one of my research interests. Okay, one of the key and major advances, okay, in antiretroviral therapy and treatment process is the steepest reduction in numbers of TB-related deaths have been among people living with HIV. Okay, so it can see, wow, well, look at that. Okay. 2021, the number of the steep decline, okay, in the context. So, obviously, complacent because TB as a whole is still the most commonest core infection, which is AIDS finding in the world as a whole. Okay, yes, okay, in the context globally, one should think. So, UNAIDS sat back and think, right. Can we be a bit more ambitious? Maybe we should talk about the 95%, the tens, okay? In the context that perhaps we can talk about, for example, here, targeting for 2025 that we're going to see less than 10% of patients experience gender equality and violence, less than 10% experience stigma, less than 10% of countries have punitive laws and policies. 95% of patients with confirmation of prevention, 95% have got know their key status, 95% we've known their status, 90% of them have virological suppressed. So now they say that, right, okay, even though you're not achieved 90, 90, 90, let's push it up to 95, 95, 95 and see whether perhaps one can get a bit more focus. Okay, so the 90% of people living with HIV and people at risk are linked to patient-centered and context-specific integrated services. Okay, boy, don't I know it, okay, in the context that some of the care for the patient, unfortunately with HIV, with co-infection are slightly fragmented. They don't actually attend a one-stop clinic. So what do I do in South Africa and Nigeria? Okay, they all get their care. If they got TB, one clinic. They got HCV, one clinic. Okay, so they don't. And if they're pregnant, where do they go? The women's health team is next door. Okay, so we jointly look after these people because they're not going to go and attend now multiple clinics. Okay, in the context because of the environment that they're in. So how about the Asia Pacific region? Okay, in the context that yes, there have been success, minus 14%, okay, minus 51%, okay, in AIDS-related death. So I'm going to run through this very quickly because some of this data has been shared with you by Dr. Chang. 14% decrease, which is actually reassuring, 1% in AIDS-related death, but we still got 6.5 million people. New infection, as I mentioned to you, and the death of 100,000 people. And that only 78% who knows the status, 65 and 62. And the funding gap that has been problematic. Okay. The how about the medium HIV prevalence among the key population? We're talking about some of this key population. Who are the key population at risk? Among Asia Pacific region, about 1.1% prevalence of sex workers, and these are medium HIV prevalence, okay? 4.7 gay men and other men who have sex with men, people who inject drugs, 4.2, transgender, gender, 3.9, people in prisons, 0.9, and we think among the adult population between 15 to 49 age, it's and that is data that is actually that we have, okay, in the context that you want to see whether if you're going to end AIDS target, then you need to actually avert the 100,000 new infection and ends target 300 new infection, 30,000 new infection. And yep, I just want to again just emphasize what Dr. Chang have said to you. Look at Philippines, 237%. The physician that shared with us were, okay, they were trying to think how innovative ways can we actually try to diminish some of this new marked increase. It's got some religious connotation, it's got some cultural connotation as well. As you know, Philippines is actually a very much a Catholic country, okay, in the context. And talking about sex is a big taboo, okay, in that context. And you can see percentage change again in AIDS-related deaths in the world as a whole. And what is the worrying bit? Okay, globally, which country? Pakistan. Okay. Pakistan. It has to do with context. And I think it's quite important for us to bear in mind, not obviously just thinking about Asia Pacific. Singapore, as you probably know, they have just recently reverted their legal law. Singapore has done well, okay? Even though they have tolerated, okay, the whole thing about MSM, people have never ever get prosecuted. But look at the number of reduction that they had in new infection, okay? So they are doing something quite right there in terms of access and accepting, okay, people's sexuality much more, okay, in that context. So I'm not going to go through this because Dr. Chang has actually gone through this, and yes, he has actually shown you this particular slides as well in terms of distribution by population, but this is 2020 data. 94% of new infection among key population and the partners, and who are those people? Okay, 53% are men who have sex with men. Okay, and here again. Now, why am I showing you this? Lead presenters, and Dr. Chang mentioned that I've got a particular research interest about lead presenters, okay, in the context in terms of trying to reach out and trying, and we're talking about lead presenters, people who presents with a CD4 count of less than 200. But in actual fact, in the United Kingdom, we are now using the definition of lead presenters as less than 350. So if you actually includes that, 41% plus 25, we are talking about 65%, okay? My chief medical officer will fall off his chair, okay? If you, what? You mean your new presentation, 65% of them are lead presenters, okay, in the context? So what have we done, okay, in the United Kingdom and trying to share? And this is hot news. This was just released literally on World AIDS Day yesterday, okay? So this is government urge, okay? Government urge to expand opt-out HIV testing program, okay? This is actually, this is a parliamentary report, which are not meant to be made into public, okay, in the context, because it's members of parliament, okay. The Secretary of State is being urged to mark World AIDS Day by expanding an opt-out virus testing program that identified people living with undiagnosed HIV or hepatitis. More than 500 people, 550 people with undiagnosed HIV were identified in the pilot program run in hospitals in London. There were 22. Brighton, Manchester, and Blackpool. All patients having blood taken in A&E would be tested on an opt-out basis. It is estimated that from this mathematical modeling, 4,400 people remain undiagnosed. So really, really pleased because I initiated this work in 2011. We were one of the first group of people that started to offer HIV testing in acute medical admission in Newcastle upon Tyne. Clinical medicine didn't have any hesitance upon when the paper was submitted, when they saw the data, it was accepted literally within a week, okay, because it was innovative. In the context that what actually happened, I'm not through a bit of it, we actually just tested people, okay, where there are nearly 4,000 eligible patients that were admitted over that period of time, okay, and literally board said, unless you have any objection, we are routinely taking your blood to be tested for HIV. And we identified over the period of just 3 months, 6 individuals. Oh, Newcastle upon Tyne, a low zero prevalent area, 6 people. And what sort of test did we use? Point of care testing, literally so that you know that the patient have got a bit of issue with blood reactivity, confirmed subsequently by ELISA competitive blood test. So HIV, right? Hepatitis C, syphilis, surface antigen. This kit, can I tell you, it's available in Malaysia. I don't. Suraj was actually discussing with me. He said, no, the project that you did, what kit did you use? Okay, and apparently it's about 15 ringgit. Okay, so it's about literally, if you convert, it's about £2. We get it very cheap, a bit cheaper. Okay, but because it was a study that we did, we got it funded. Okay, so. Well, okay, you need to get people diagnosed there and then, okay, tell them that, I'm sorry, one of your blood tests have shown that there's a line there, we need to take extra blood, okay, in that context. So the treatment cascade. So therefore, I'm not going to dwell on this too much, okay, at the moment, okay, because this has been highlighted to previously, okay, key population as well, okay, in the context, and missed opportunities. And that's what I want to actually perhaps focus on. Proportion of people with HIV who know the HIV status, who are on treatment, same-day initiation of heart in the Asia-Pacific area, okay, in the context to see where are they actually being initiated on. Yeah, so there are parts of the world that you can see it's not possible to start heart on the same day as HIV diagnosis. People away and are on treatment. So therefore, can you see, not really very successful, but what is worrying is patients aware of the HIV status, but not on treatment. It varies, okay? And again, Malaysia here, okay, you can see is round about nearly 40%. So that's missing somewhere. So these people who are not on treatment are potentially the source of able to transmit the infection, okay? And I am a bit skeptical about the data from Burma, okay, in the context, but China is actually quite this particular program, okay, and so is India, okay, in that context. But unfortunately, for India, okay, this green, it's possible to start ART on the same day as HIV diagnosis. Right, so we are really lagging behind prevention targets. So therefore, we need to think through and make innovation and advances in HIV prevention as shown here in parts of the world and Asia Pacific area as well. And yes, I think it was a brilliant study. It's a bit dated now, so you have to keep yourself hidden. Okay, perspective from a Malaysian who have sex with men on policy, network, community, and individual influences on HIV risk. Fascinating, okay, in terms of this piece of work, okay, that's been done. There have been actually, in fact, evidence from 14 randomized trials, okay, compared to standard HIV testing, doubled up, particularly on HIV testing in the population that is looking at to have a whole don't have a how are they going to get the test kit? Okay, so yes, that's obviously innovation, but it's actually a good step that anyone log on, request, send kit back, send it back, and therefore, if you are reactive, you are sent a message by text, which clinic that you go to. Okay, and there is no doubt. Okay, such testing doubled the uptake of HIV testing in the general population, increase in the range of delivery models, positive linkage to, which is very important. Misuse of kits, obviously, self-harm, adverse events when reported when not temporarily, and relationship breakdown and resolved within days. So, on how to get people tested, okay, is very important. Self-testing and self-sampling, okay. This is work that has been done from the Malaysian AIDS Council, okay, and which a program which has been highlighted too, because obviously the perceived stigma, discrimination by healthcare providers, because some of these people still feel discriminated. I'm not quite sure how this doctor is going to react to me. No, when I say I want to have a HIV test and I am an MSM or injecting drug user or I'm a transgender. Okay, so therefore you can actually do this particular test, okay, and in a context without that barrier, okay, and therefore I think self-testing is actually one of the king, okay, and they can see the initial results, okay, in the context that they had total registered, and yep, there's about the number of those individuals that does not want to be tested because they have to go do a pre-test survey, and they send out 3,000 kits, okay, and over 1,000 of them are reported and post-test, okay, and have a look. Oral-based blood, okay, the self-testing, there are a range of, over that period of time, positive tests that has been done. 70 out of the 1,260, okay, in the context that are positive, okay. So these are otherwise much like, okay, the opt-out system, but this is focused. Okay, how do you actually encourage people to come and actually get access to the program? So that's where the challenge is, okay? It's out in the community, but people need to be aware of it. And more often than not, it's by word and mouth, okay? People heard about it. I can go and get a test done, okay, in that particular mobile van and so forth. And really, really delighted, okay, which has been highlighted again by the previous speaker in the context of the updated, okay, guidelines for treatment. So that's the one, okay? Right. Rapid initiation, okay, same day I have talked about it and I just want to just mention this again because as you know, in some setting, when someone has got a diagnosis, okay, you talk through with the individual, is he ready to get on treatment? If he's ready to get on treatment, he must be started on treatment, okay, and in that context, and again, can see, okay, in one of the ways of actually starting people on treatment. Pre-exposure prophylaxis, ooh, huge topic here in Malaysia. Okay. I'm pleased to note that this is now accepted by MOH. One can actually do a prescription and being paid by the government. Okay. So there has been systemic review evidence that it actually works. Okay, it actually works. Okay, and look at to see how it has actually been the data of efficacy. The PROUD study shows that you can actually reduce transmission by 86% using PrEP. Okay, and in context, the important aspects of trying to actually prevent the transmission. Right, okay, in the context of how we actually implemented an access for the individual. And in New South Wales, okay, you can look at the 24% decline in HIV diagnosis, 42% decline in HIV diagnosis in Australian men MSM, 11% reduction in overseas-born MSM. So there's no doubt it is evidence-based, okay, in terms of PrEP, pre-exposure prophylaxis, which means taking a cocktail of antiretroviral drugs before you get exposed, okay, in the context of sexual activities. So stigma, I'm going to finish about stigma now, okay, in the context in terms of major barrier to HIV sepsis. Now, lots of work that has been done, okay, on stigma index in 14 countries in the region. You can see 61% feel ashamed, 7% denying, okay, services, multi-layers of stigma experience, okay, in the context, and really at the end of the day, they can't get access to health services. Evidence-based again, okay, it would be in terms of MSM here in Malaysia. There's been quite a fair bit of work that has been done, okay, in that context. And how do you feel about these types of patients, okay? And again, this is the student, okay, a survey in the context of general patients. You can see patients with HIV, wow, okay, patients with infectious diseases and MSM, even with this concept, and you are already being discriminated. The three fundamental functions of stigma, you keep patient down, you keep people in, you keep people away, okay? And the evidence in HIV is really, really strong. Now, it have an impact on mental health, behavior, physical health, and obviously, you know, the unique stresses in itself has actually been a challenge. And the optimal delivery of signal intervention tool is that what can we do is at a multi-layer, because if you just do a longitudinal intervention, it does not lead to lasting change. Multi-level, it can change at one level, but not sustain without changes at the other level. Multi-component, there's no one single tool, unfortunately, that can eliminate stigma. Many tools are needed, but the challenge is, okay? And yep, okay, and the systemic and in terms of how then you actually want to access, you know, the testing as well, and treatment. You will need these centralized mobile testing strategies. You need to be able to use community health workers, peer workers. Okay, peer workers is actually crucial. Okay, in the context, same-day testing and ART initiation, deployment of your peer workers significantly improve virus suppression. Task shifting to home visits. Poor resource country. Okay. And the use of technological and digital innovation and test intervention can also supplement the effects, okay, in particularly to reach the 90, even the 1990 or even the 1995, okay, targets. So just to show you, okay, some of the work that has been taken, okay, and this is some of our work in Nigeria, okay, which was actually funded by the Commonwealth, a PhD fellow that looks at why is it in the middle belt of Nigeria, in Abuja, that there's a high prevalence of HIV as compared to the north and south of Nigeria. And it's fascinating. This is doing on terms of identifying the key themes, okay, and regional variation, and can also ignorant about sexual transmission in that context. So visual prevention, phone-based intervention, you broaden the reach, you want to differentiate the service delivery, you target reach and improve efficiency, visual outreach, influencer advertisement, you need to have a team well, okay? We were just discussing before the event in terms of that. There are very few people like Professor Shiva, like Dr. Chang and myself that will actually stand in public and talk about HIV, okay? In the context, because we actually like to be able to, promote, okay, in the context of understanding and the general public awareness. I can tell you there are a number of doctors who doesn't even want to get involved with HIV. Unfortunately, that stigma still exists. And these are the type of digital HIV prevention, which I'm not going to bore you, okay, in the context that can be innovated, okay, in the context of wanting to actually trying to prevent, okay, transmission and stigma as well, okay? Yeah. It's quite interesting, this particular article that look at 38 United Nations member states in Asia Pacific that has got legal barriers to HIV response. Look at that. There are 36 states that criminalize some aspects of sex work, 18 states that criminalize same-sex relationship, 15 states that the law does not allow for possession of a certain limited amount of drugs for personal use, 21 states that criminalize the transmission of non-disclosure or exposure to HIV transmission, 14 states that restrict the entry and stay and residence of people living allowed to come to my country, okay, in that context. So I'm going to finish with this hero of mine who unfortunately died in a crash, okay, in the context, Jonathan Mann. He's a United Nations AIDS program. He said, and just as the epidemic was not only about the virus, so too the response to AIDS could not be just about health, but rather about humans and about empowerment. He understood that the basis of the epidemic was the virus. However, he also saw that injustices and human rights violation fueled the epidemic. Getting serious about human rights means improving the health of the ill individuals, but also assuring their dignity, safety, security, justice, happiness, all essential to health. Okay? And I'm sure some of you who are as old as I am would recognize this lady, right? This is Elizabeth Taylor. She is really one of the champions, okay, for HIV internationally, okay, in the context. Malaysia needs a champion like this, who is really prepared to be on television, on the press, to say, hey, this is how we're going to destigmatize HIV in the whole. So thank you very much, okay, for your attention. Yep. I think we can go to the next speaker. Okay.
So thank you, Prophet, for the wonderful talk. So now I'm Shu Ping, one of the alumni from Newcastle and the teaching fellow for the current students. So let me briefly introduce about our last speaker before giving the floor to him. So he's Prof. Siva Kumar, who is the head of clinical school, Johor for Monash University. And he's also the associate professor for psychiatry in Monash University. And he has specialized in this field for 22 years with his special interest in the field of addictions, medicines, and harm reduction. With that, he's also the current president for Intan Life Zone, which is an NGO working in the field of HIV and harm reductions, servicing the people at the most risk populations. In his capacity as a researcher, Prof. Siva has actively conducted research projects in the field of mood disorder, addiction psychiatry, harm reduction, co-occurring disorder, and microbiology. With that, he will be discussing more about the term of the year, which is led community leads. Let's invite Prof. Siva.
Hi. I suppose I'm clear. It's okay. Right. A very good morning. And before I start, I'd like to extend my deepest appreciation to the society, the president, Prof. Ed, Dr. Chang. Very honored to be here. I was, in fact, supposed to be here last year. And I somehow was not around, so someone from the society actually came. So before I introduce myself, I think most importantly, I may be all that, but I think I feel proud to say that I'm from an NGO called Intan Life Zone Welfare Society. And I'm quite sure that most of you have not heard about us. We basically do harm reduction work, and we work in the field of HIV, harm reduction, moving on to Hep C in the state, for the state of Johor. I have been the president for a couple of years, and through that, we actually do a lot of HIV work on the ground. So I'm going to speak about a few experiences, and it's not going to be as scientific as Dr. Chang and Prof. Ed, okay? But it's going to be things that's on the field, you know, in the field, things which are quite practical about why and how societies actually have a role. And this is actually, Led Communities Lead is the theme for 2023 World AIDS Day, UN AIDS, you know. So before I even start, you know, let me tell you a story. So this man, he lives by the edge of a waterfall. And every time he tends to see people falling from the cliff down from the waterfall. And each time someone falls, he runs there, he takes the guy up, he resuscitates the guy, and he treats them. So every day he finds people falling from them. And he's so busy trying to pick them up and reviving them that he has never actually gone up, you know, and seen, why are these people falling? This is exactly the state of things in Malaysia and in most countries. We tend to treat and spend a lot of time and effort treating. We forget about prevention. We totally forget about preventing people from actually getting the disease. And I echo what Dr. Chang, Prof. Ed said, prevention is the way to go. So I'm going to take a few steps behind, you know, and tell you why and how we actually came to these decisions and all these movements. In the early part of the new millennium, when we actually looked at our Millennium Developmental Goals, you know, people actually got a shock because we were so close to what China and India was achieving. We had huge numbers of HIV and AIDS among the Malaysian population. So huge that, you know, we were actually scared. We had to do something about it. And that also sort of affected our developmental process, the country's developmental process. And basically it shows that, you know, we've got huge numbers at that time of people living with HIV and AIDS, and a huge number of people actually dying from the disease. And when they actually looked closely, they found that a large amount of them got the disease from sharing needles. So we're talking about a group of people who were having problems with addiction, people who were sharing needles, injecting needles, compared to heterosexual, that means through sex. At that point in time, okay, it was only 12%. And when we look at bisexual, homosexual, at that point in time, very small numbers compared to sharing needles. And this goes back to addiction, drug addiction, and how the country actually looked at all of them, you know. So when we actually looked at, just let me just move on with, oh, nope. Okay, sorry, my slides jumped. Okay. All right, okay, no problems. I think I sent a wrong set of slides, but no problems, happens. Now, the reasons why these numbers were huge was how the country actually looked at addiction and how the country's policies were. One, the policies always stigmatized drug users. So at that point in time, there were very little services. Now, a drug user couldn't actually walk into a hospital and get help without getting his name on some record, or he's looked at as a number, So people started taking statistics. So that's a huge thing. So if I were a drug user in those days, I wouldn't even go and see a doctor. The fear of actually being looked at in a different way. So there was huge stigma. Prof. Ed actually spoke to you about stigma. And there was huge stigma at that point in time, really huge. So people actually never went out to get help. Now, what this actually did was this caused a hidden population. So people were actually hiding, people were actually not going for help and continuing to use drugs. And there was a lot of needle sharing at that point in time. So needle sharing would have been the best way or the fastest way to actually get the virus. So that's number one. Number two, there was very little options for treatment. There were very little options. If you had stepped into a hospital and asked for any help, the first thing that you'd do is they would actually report you to the police, and you'd most probably land in jail, or if you're lucky enough, a rehab center. That's very, very, very little for you. So that's also not going to help people. And the third point is there was huge stigma in the community. So nobody actually goes, talks to people or asks about things. So these were three huge things that basically attributed to those huge numbers. One, policies, the country's policies. Number two, human rights. And number three, stigma. So these are some statistics. Now, these are not international statistics. These are statistics from the state. Okay, so this is from the state of Johor. So with the cooperation of the Johor Health Department, actually, these are statistics that I've got from the state, and it goes right up to 2022. All right. Now, as you see, with those numbers, okay, huge numbers, what happened after that was the government basically brought in plans to change, So they brought in something called the National Strategic Plan. And we are actually now on a newer plan, which goes on to 2030. Now, some of those plans were basically to immediately work on numbers, to immediately strengthen advocacy, training capacity, and most importantly, reducing HIV vulnerability among the injecting drug users and their partners, because they noticed that that was a huge, huge problem. And by saying that, reducing HIV vulnerability among the IDUs and their partners, they basically started off projects that the community could actually do. Now, why bring in the community? The reason was all this while, the entire thing was top down. That means people who were doing the treatment were people from the hospital. We are talking about doctors, nurses, and the healthcare. And the thing was, many of them could not penetrate communities where diseases were actually, HIV was actually very high. So you needed to go right down to the grassroots and get people who could actually penetrate these places. That means we are looking for people from the community themselves. Okay, and who are these people? I mean, Dr. Chung spoke about them, Prof. Ed spoke about them. These are people with or who are the most at risk. So we are actually talking about people from the transgender community, people from the MSM community, and also people from the sex working community. So these are the people that we work with, and in our team that actually goes out and does services, we have employees that work with us who come from the community. So if I'm going to send in someone into the transgender community, I send in my employee who is a transgender herself. If I'm going to go and work with the MSM community, I'm going to send in someone who is an MSM himself. All right. So that's the only way you can actually do those things. And we started off projects, especially one that was started very long ago, was called the Needle and Syringe Exchange Program. okay, the NSCP. And this was something that was remodeled from the Australian program. When we actually initially started this a very long time ago, the fear and the lashback from the community was, are you actually going to attract more needle users, And are people actually going to try needles more and put people more at risk? Our numbers going to go up? But over the years, the one thing that we found out was that the numbers actually came down. And those are good examples that we see in the state. When we started off, with the NSCP, which is the Needle and Syringe Exchange Program, along with the Methadone program, we find that the numbers gradually came down, okay? And this is the extended Ending AIDS national program. So you find that the numbers actually went down when we actually started with the Needle and Syringe Exchange Program. So what do they actually do in this? Oh, sorry. What do they actually do in the Needle and Syringe Exchange Program? We've got people going into the community. And it's quite interesting when you actually speak to them. And I have been on once or twice. I've got my boys who actually go in. These are dangerous places to deal with because you're going into the so-called pods, okay? Now, pods are basically drug dens where the users go in and get their drugs. They can basically buy drugs. They can get someone to inject drugs for them, okay? And these are basically very dangerous places. So the workers or the community workers, we call them, they actually go into these places, not into the dens, but somewhere around those areas. And they start chatting up some of the people who are actually, or the people who frequent those dens. And being from the community, because we are dealing with drug users, so people who work with us are people who are in recovery themselves. So they know you are from the community and you know each other. So one thing is gone. The rapport is basically established. If I were to stand there and talk to someone, people will run away, So none of us can do that job. So it worked very well when you actually sent in people who were in recovery, people who were their friends. The only difference was they are no longer using. So they built rapport so fast. People trusted them, And these people were all trained. So we trained people on the field. We trained them what to say. So they went in there. They not only gave needles, but they took that opportunity to actually speak to people and gave them some amount of health education. They also taught them ways how to clean the needles, how to inject in a proper way. Now, the belief in harm reduction here is going in and telling people to stop a habit that they've been doing for the past 10, 20 years is going to be futile. Nothing's going to happen. But eventually, what happened over a period of time, the boys found out, or these community workers found out, people get tired of actually injecting. Eventually, you can't find veins, and you want to do something else. You can't stop the withdrawals. You need something to be done. So that's where the opportunity comes in. And they also took this opportunity to ask them, do you want help, medical help? And if they said, yes, I have this pain, I have this cough, I'm not feeling too well, they said, follow me to the hospital. Let's go see the doctor. So what the workers did, or what our community workers did, is they took them by the hand, brought them to the hospital, and got them to see the doctors. And the good working relationship that goes on with Ministry of Health and the NGO was that we made an agreement. We have no waiting line. We go in there, we tell the doctor, we go through a back door, the doctor sees them almost immediately. So they don't have to wait there, and there's no waiting, staring around, stigma. And that worked very well when we actually worked with the community from TG communities and the MSM communities, because they don't like sitting and waiting. But they were a different group of communities that I'll basically talk to you about. Now, what happened was, this worked extremely well, the Needle and Syringe Exchange Program. So people basically took up that idea. Okay, I'm not going to look for needles, I'm not going to share needles because I've got clean needles. So we tell people, don't share with your friends, because we're also giving your friends. And we're coming back after a few days, return your needles and I'll give you new needles, you know? And until a time where you're tired of injecting, tell us. We'll give you an option. And what was that option? That was the methadone treatment therapy. So almost 50 to 60% of the people in the methadone treatment therapy were referred to through people working. So when people reach out to you and say, I'm tired, is there any other method? Yep, let's bring you to the clinic. Let's get you a place to get methadone. So it worked out very well, reaching out to people. Now, that was the outreach work that actually worked out very well, because I think that's the only way to reach out and get people, you know, reaching out. So waiting for people to walk into a clinic is never, ever going to happen, because there's a lot of stigma. Tell you a story that actually what happened when we started out all these things. So people from MAC and Malaysian AIDS Council came down. So they were running a small test whether staff at the primary healthcare centers knew what HIV testing was and how confidential it was. So this one gentleman was a good close friend of mine. So he went in disguising as a patient, and he went there and he went to the counter and he told, well, this all happened in Malay, and he asked the nurse, you know, I want to test for HIV. Do you have HIV testing here? Obviously, the person who was sitting in the counter, the front counter, didn't know anything about HIV testing. So what did she do? She basically looked at her friend who was a few blocks away, you know, a few blocks away, and shouted at him, do we test HIV here? This guy wants to test for HIV. That's confidentiality for you, okay? So we had to work on all these things, you know, we had to work on with all these things. So sending one of your clients alone is never going to happen. You're going to lose them between the creeks, you know, and that's where the outreach workers take them, hold them by the hand, bring them there. Now, it works well, you know, because if you're a drug user, you're not visible unless obviously people can see the injecting sites. If you are MSM, nobody will know unless you go out there and say, hey guys, you know, I'm gay or something. But if you are a transgender, sometimes, you know, many a times it's quite widely visible, you know, and sitting down there, you may stick out as a sore thumb and people would stare at you, you know, and that's how the community is. The community hasn't really accepted. It's getting so much better. I think people from the transgender community have started getting jobs in supermarkets and shops. I'm sure many of you have actually bumped into many of them. So yeah, you know, it helped a lot when we actually got people to bring them. So the outreach worker would follow them for all follow-ups, follow them in, sit out only if they were uncomfortable, but, you know, take them for all follow-ups until a time where they felt they were so much better to do it by themselves. Another thing that Prof. Ed brought up and Dr. Chung also talked about was testing. So this group of people would never step into a hospital or primary healthcare center to test. Testing needs to be done in the community. So the next step that we actually did was to train the healthcare workers to do the testing. So the healthcare workers, and we are talking about healthcare workers who are not doctors, who are not nursing staffs, are basically day-to-day people, you know, from the community who come in to do this work. So they were trained how to do testing, how to do those rapid tests, and they were certified by the local health departments. Then we send them out into the community and get them to be tested there. So where do you test these people? The drug users, you have to test them out in the port, you know. The MSM people, you got to test them where they are. Okay, so certain areas, you know, where they collect, like clubs, spas. The transgenders, an ingenious idea that they actually came up with how to test people was to run, you know, how many of you have actually have friends among the transgender community? Good, all right. Now, interesting group of people, you know, very outspoken, and in Johor, for some reason, they are always in businesses, fashion and what would I say, show, you know. So they run and we had one person, she basically was running beauty pageants for the transgenders for the country. And so we used to run some of these shows, you know, and we worked with the Ministry of Health, thank God, otherwise they would come and catch us. Some of us would have been sitting in prison, and we used to run these shows. I mean, it's a beauty pageant going on, and you find a whole group of transgenders coming there to attend that. And this was a good opportunity to actually reach out to them, tell them about opportunities, trying to come do some testing, you know, and through that, we actually got good numbers, okay? So we actually got good numbers. So these are some of the strategies that we basically do have on the ground with the communities. So looking back at cases, you know, in terms of risk categories, it is no longer the same picture, just like what the statistics were shown, you know, earlier. You do not find high percentages of new HIV cases among needle users. That's gone down tremendously. That's really gone down. But we are fighting a very strong battle to get numbers, new cases among the MSM population down. And just as what we have actually spoken earlier, vertical transmission is almost zero. It's actually zero. It's actually zero. So we have basically eliminated that, and that's, I think, tremendously good. You know, that's one thing that we've done tremendously well. But yes, some of those most difficult to reach population are people from the LGBTIQ population among the MSM. So reaching out is going to be very difficult. Some methods that we use to reach out are through apps. So some ways have to do. Sorry, I got wrong slides in. I'm just going to go back to that. Some ways of reaching out to them would be using apps. Like for example, the MSM population have got specialized that we actually reach out to, advertise, and make meetings, and then tag with them. So they're still very much on the apps. The transgender population do still openly meet people. So that's much easier. Whereas the needle using population, now those is through contacts going into specific areas. Post-COVID, the entire scene or the scenario has changed. It's no longer that same scenario where ports are open, where people have got drug dens. Many people use drugs and get their drugs through couriers. Okay, just like how you order Food Panda, you know, and all those things. Yeah, but obviously I'm not incriminating Food Panda for drugs, no, but I'm just saying that's the way, you know, you put an order online, you know, through a dealer, the dealer drops it off, rarely at your home, but at a meeting point. So contact is very important. So dealing with them is one way to do. So the way to go from here, all right, the way to go. I think great effort has been done at the treating centers, community healthcare clinics, where we've got many of them where we've got HIV specialists sitting, we've got hospitals. But my feeling is that it should be strengthened at the community level. So empowering community should be the way to go, because that's the only way where you can actually reach out. There are hidden populations, people who basically don't want to go out. You know, so we may be looking at different groups or pockets of people other than the LGBT population, you know, but within the LGBTIQ population itself, there are groups of people who really don't want to go, people who are scared of being discriminated, of being stigmatized. But when you actually empower communities and you work within the community, you find that penetrating those groups of people are so much easier, number one. Reducing the numbers of relapse, of people who basically start and stop treatment, going to be less. So just like what Prof. Ed said, this is not a problem, not a disease or not a disorder where you sort of detect and give an appointment for treatment. You've got to detect and treat immediately, and that's the way to go. So people in the field should be empowered to test. That's the best way. So self-testing is one, empowering people themselves. Number two, training the outreach workers to get into the community and do the testing themselves. And that's the only way to get our numbers up, right? So I suppose that, I'd like to end here by saying that that's most probably one thing that all of you can do, when you're going out there. And I suppose that the fact that you're here is because you have an interest or an invested interest in the field, And when you go out there, remember that a doctor's place is never in a hospital, all right? It's never in a hospital. It's actually in the community. So get out there, okay? Deal with the community, work with the community, and you guys can make that difference. I'm just going to end with a saying that from a poet that I like, Rabindranath Tagore. Those of you who have not heard of Tagore, and Tagore said, you can't cross the sea merely by just standing and staring at the water, So and idealing and, building castles in the air take you anywhere. You've got to get out there and do things differently. Begging on that same door over and over again is not going to help. You've got to do things differently. And I hope the government actually puts funds into empowering the community and, trying to get those numbers up. Thank you.
So now we're going to be hosting our Q&A session. So if anyone has any questions that they'd like to ask to our fellow guest speakers, you have the floor to do so now. So any questions? Yeah.
Can I start the rolling? Okay. Can I also highlight to you guys, I think Professor Shiva is very modest. There are very, very few people like him in the whole of Malaysia who go and actually work with people out there in the community who are marginalized, very, very hard to reach, okay? And that's where the key bank should be, okay, the context. We must show compassion, we must show empathy, and we must think of innovative ways to reach out to this population if we are ever going to end transmission of HIV. Okay, they need to feel that they are there for us to be able to help, to be able to think through, and what you all, not just in medicine, it's all over how you approach an individual to have a shared decision ability. I think that's quite an important thing. Okay, there's sort of a shared decision in that context.
Thank you, Doctor. So does anyone have any questions they would like to ask to our guest speakers for today? No?
Yeah. So I mean, I think all three of you sort of mentioned like how there are multiple layers of stigma, especially people in sort of vulnerable and marginalized communities. And we see that HIV is definitely more prevalent in, the LGBTQ community, sex workers, drug users, and things like that. And for, I guess, also in Malaysia maybe, but we do see sort of legal repercussions in people with, who are either, drug users or sex workers and so on. And I guess my question is, how can the healthcare system sort of be more supportive or less stigmatizing while working within the legal framework? Like how, like for you, you didn't mention how we go out and do outreach work. Is that exempt from like the legal aspects of the like country? Do they not face any sort of repercussions, and how do you work around that?
Thank you for the question. Yeah, it's a huge problem when you've got a legal system that says otherwise, and the entire effort coming from the medical profession, which says just the opposite. I give an example. When we actually started off with the needle and syringe exchange program, many of our outreach workers were caught by the police. And they were sitting in prison, and we had to go bail them out. The sad part about Malaysia is we all work in silos. So what the police does, the health department doesn't know. Okay, even within the health department, sometimes, sorry, Chan, we do work in silos. Even though it was very clearly briefed, because remember the entire harm reduction program by the government came through the Ministry of Health to the Malaysian AIDS Council, and it was a top-down directive. So all the police officers were briefed. But people in the police officers who do these arrests don't sit up there. They are basically those police officers in the ground, on the ground, and they were never briefed. So it took years to actually go meet them, talk to them, and explain about these programs. And now it's so much easier. So my outreach workers needed to be careful. They needed to be a distance. So they were not only worried about being caught by the police, but also being attacked by the gangsters who ran the drug den. So two dangers at one time. It's a double whammy. You don't get hit by that, you get hit by this. Nowadays, it's much better. After many, many years, they go in with a badge. And which says that they are from IZ, internalized zone, and they do have the Ministry of Health emblem. So it's much easier with the police. But then, having a Ministry of Health emblem sort of puts you on the other side, So it's always going to be a huge problem. But where the problem starts is when you're dealing with clients who come from the MSM population and the TG population, because these are bigger policies that you're going against. We go in with a very neutral mindset. So in no way are we going to advise them against this. So what we have actually done is we started working with our key stakeholders. And some of the key stakeholders, other than the police, is the religious department. If you don't believe me, the religious department have actually taken a 360-degree turn in the state of Johor, at least. Okay, I'm not talking about the rest. The religious departments now do not talk about converting, going back to normal. They just talk about religion whenever they have to have those things. So it's so much better. So we had to bring in these people, we call them the stakeholders, have regular meetings, talk to them about the bigger picture. We're not talking about the behavior, we're talking about the end product of the behavior. If we sort of enforce laws against them, these people are going to hide. And when they hide, they're going to do the same thing because they're not going to get help, and they put themselves in danger. And what happens if one person has been diagnosed HIV? Obviously, it spreads. The best way to stop that is by getting help, immediate help and intervention. So through that, we've sort of got into this working relationship, till a time where national policies look and treat LGBTIQ otherwise in the country. But strong efforts are being put, but this is a very sensitive issue, so we don't change it overnight.
Okay, is anyone want to ask any other questions as well? No? Yeah. Okay. Any other questions? No? Nothing? Okay, I have one for Dr. Ed. So it's more specific towards the UN AIDS goals. So, sir, you've mentioned or you talked about specifically about 2025 UN AIDS goals. How would you feel like, sir, since there's the sustainable development goals that we have to achieve by 2030, do you think that perhaps like with Malaysia's role towards, combating HIV, would it be possible to kind of achieve the 2030 goals or?
Yeah, good question. Okay, I think it's good to actually set a goal, but the goal is not just simply a figure that has been plucked out from the air. There's a mathematical modeling, okay, in the context to see, right, we know the biological dynamics, okay, of the transmission, the characteristics of the behavior, characteristics of transmission risk, and therefore, right, how did what I should have mentioned earlier on when I talk about 2014, where they decided on the 1990 goal, was that on the mathematical modeling, that is going to be the M that is likely going to actually interrupt transmission of HIV. So now, obviously, we are not going to meet the 1990 goal. Some countries have met it. I'm very pleased to say that United Kingdom has met it, okay, because now, we have got, obviously, what we want to actually show now is finding the undiagnosed. And that's what we are very, very concerned about. Look at that particular work that at this moment, based on that piece of work about opt-out testing, the mathematical modeling shows that there's actually 4,500 people that are still remaining undiagnosed. And those are the individuals that may not perceive themselves to be at risk of HIV, and it's not going to come out, okay, to be tested, okay, or come to be tested in that context. And I think, yes, it means that, right, you've got a target, let's work a bit more onto it. I think, Malaysia has got a fair bit goal, okay, but at least there is people that is working in the front line. What we need to be able to persuade, and I hope, all these senior people up there with money and funding will hear this YouTube in the context that, right, okay, we didn't realize this is still an issue, okay. But some people think that because they don't see it, it doesn't exist, okay. They don't think that it's going to exist. And therefore, I think a bit of focusing, a bit of change mindset is actually going to be doing quite a lot. What? You start off with 90. Now you want 95. Yeah, we better pull out our socks. If you see, that's what I meant. Okay, the context that minimum standards, okay, in the context of what we think we can achieve. Yeah.
I think it is, yeah. I mean, it might sound impossible at this point in time, just because we are not even achieving that 90. But I think putting something there for us, in the event that we hope to achieve, I think that is going to be, motivating all of us to actually take part in combating the pandemic. Yeah.
Yeah, sure. Please.
I feel that plan that I mean the program that UK is doing, I mean, trying to diagnose the undiagnosed, the opt-out technique, I think that's the way to go. It just struck me, how do countries actually get around ethical issues around this, and how do we actually respond to someone who says, who's been tested and said, hey, I didn't know there was an opt-out technique, and now you test me and I'm positive. What do we do about this? This is unethical. I just wanted your thoughts on this.
Yeah, I think that's very challenging, okay, in the context, because why they've chosen those 22 hospitals is in terms of as a pilot, is in terms of prevalence around that area. So they know that in United Kingdom, what they regard as high prevalence area is 2 per 1,000. If there's a 2 per 1,000 prevalence of HIV in that geographical area, that hospital took part in that pilot study. London, Birmingham, Brighton. Okay, so that's why there are 22 hospitals. There is a huge notice, okay, coming in, and in actual fact, a patient actually, the study actually show, okay, it's actually, there's a consent that they sign, okay, to say that we are routinely testing HIV for everyone that comes into the hospital, a hospital setting. Do you have any objection? There's a little box as people tick, and surprisingly, no, in that pilot study, they didn't have a single objection. Same as the study that I did in 2011, where in the acute medical unit, the only people that we couldn't actually test is people that did not have mental capacity. The people that got neurocognitive impairment, okay, because they cannot read and tick the box, okay, in that context. But very good question, okay, in the context that, I mean, the challenge, okay, is, and it's great, okay, I mean, we must not forget that first line treatment for HIV treatment in Malaysia is free, okay, and that the integrase combination therapy is much more widely, okay, available, okay. FR runs based treatment, okay, in the context, because that's the way. And I think very, very important is in terms of thinking about in ways, okay, to actually diagnosing the people who are out there who are not themselves perceived at risk, because they're not going to come forward, okay, because they don't think they have been at risk. Yeah.
I actually have a question to Dr. Siva about his NGO. So, sir, by any chance has like your NGO in particular been working across Malaysia? And is there by any chance would your NGO go international to like pursue different projects and helping out people with HIV?
Different what?
Different people, like different countries, like do you,
Countries.
yeah, like do you plan going international like in the future?
All right. Well, few reasons for, I mean, we have not done it so far. Life Zone has got a couple of offices through which we run services. The main one is in Johor Bahru. We've got an office up in Batu Pahat, one in Kluang, and a bit north of Johor, a place called Segamat. So in Segamat, Batu Pahat, and Kluang, we work with the local health department. So we actually go out and see the clients there. In Johor Bahru, we have our own office where we run independently. We are very much dependent on Malaysian AIDS Council funding, where we actually get funding from overseas. So the way we work in Malaysia is Malaysian AIDS Council has got lots of partner organizations. So every state has got its partner organizations. So we try our best not to cross the boundaries and to just keep good relationships with that. So yeah, we don't, unless there are gray areas like the border of Johor and Pahang. Now, it's a huge area, and sometimes we do cover a little bit of Pahang, to help out our colleagues in Pahang. So we don't. But the other programs that I just wanted to add on, just to tell you that there are a lot of innovative programs have actually come up, and kudos to the Ministry of Health, hospital, the doctors, to curb the numbers because of that close link of HIV and hepatitis C. So we've also bordered on to the treatment of Hep C, and how we find patients is we put in the NGOs at clinics that do HIV treatment or clinics that treat addiction with methadone, and we do tests for Hep C. And then we try to detect hepatitis C and bring them for the hospital to the hospital for treatment. So that's something that's been spearheaded by our current DG of Health, Razi. Another good project that Prof. Ed talked about is the project where you're PrEP. Okay, that's pre-exposure treatment. Never would I have thought that Malaysia would have actually brought in PrEP. But it's a good thing. The Ministry of Health, working with the NGOs, have got a pilot program that's actually going on. So a couple of clinics, even here in Johor, and they work hand in hand with the NGOs. And we detect people who may be in need of the pre-exposure treatment. And we actually do send. And the numbers are quite encouraging. So that's another method to actually reduce new infections, HIV infections. So these are all very innovative things. And I think that working collaboration, the Ministry of Health, Malaysian AIDS Council, and the NGOs looks promising. So we got enough work in the state, actually. We don't need to go anywhere else. Thanks.
Thank you. Does anyone have any other questions before we close today's session? No? Oh, yeah. Any other questions we'd like to ask? Any thoughts that you'd like to share? Anything? Okay, so I think this is it for now. I would like to thank everyone for joining today's session. Thank you guys so much for joining in and listening and taking your time of day to join us on such an important day. I hope everyone has learned something new. I've learned so much about AIDS, more than I've ever had in my entire life. And I'd like to thank all our speakers for coming in today. Thank you so much for taking your time as well. And honestly, I really benefited from this. I hope other people could have had the opportunity to benefit from this. And yeah, I think this is it. But before everyone can leave, I have the token of appreciation for our speakers today. So can we all just give a round of applause to all our speakers today?
One, two, three. Okay, got it.
Thank you so much. My committee members for helping out. You're free to go, man. Thank you so much for coming. Thank you. Yeah, just wait, hold on. Just let Miss Shira know that you're ending the thing. Yeah. Just fix on the.
We're ending this, yeah, we ended the session. And then. Maya, can we leave after ending? Say, yeah.